Thank you very much, Dr. Haskins and Dr. Peterson and Sasages for the opportunity to present this interesting topic today. And I'll start by saying I have no disclosures for this talk. I'll start with the concept of really making sure we understand who our trainees are, because they may be different from the time where you or I may have trained. If you look at the figures on this slide and the information, it's interesting to know how much things have changed. The median number of residents in the typical surgical program now has 24 residents, and the average entering age of a first-year resident is nearly 30 years old. Gender and racial and ethnic makeups are listed here in these two charts, as you can see. And why does that matter? Because people have different issues depending on who they are. So who is a difficult trainee, or what is a difficult trainee? And one way to think about it is it's someone who is struggling in one or multiple ways, and we, meaning the program or the trainee themselves, may not have insight into why. We often want to categorize issues as they come up in a bucket that's clean and neat, such as the ACGME core competencies, but it's often not this simple, and you really have to take some time to understand what are the underlying issues that may be contributing to an issue with performance or behavior. I'll state the obvious also, that residency is hard. And while we're talking about trainees that are struggling now, the struggles have always been there. I think it's clearly evident that there was not a culture that allowed a lot of these things to be aired in the past. But if you look today, generationally, there are considerable differences in educational and communication expectations between trainees and often the people that are training them. Fortunately, residents tend to be now more open with their issues, their concerns, or health issues, which may be contributing to their problems. One way to think about this is there's just a lot of more stuff going on. Some of this is obviously not good stuff. There's more suicidal ideation, mental health issues, family, childcare, age-related concerns. Just a little bit of data from the University of Washington's GME office. In 2016, for all residency programs, and we have actually one of the largest aggregate residency programs in the nation, if you look at all the programs, there was one disability accommodation and less than 5 leave requests processed. Fast forward 7 years, and obviously post-pandemic, 20 disability accommodations and 80 requested leaves for various issues such as medical, parental, or other. So a lot more work that's being done to support residents. We approach the difficult trainee with a team effort. And really the cornerstone, we think, of success in our program, and hopefully for many other programs, is the CCC, or the Clinical Competency Committee. And what taking a committee-based approach allows us to do is we're able to communicate and investigate an issue with committee input. Plans are committee-based rather than one individual's take on something. And obviously working with multiple people gives you diversity of inputs and ideas on how to manage a situation. Our particular committee is based on a program director, the associate program directors, our admin team, as well as our GME liaison. So what are the main types of problems that you tend to see? I think they tend to cluster in two broad categories. And the first one really focuses on technical skills or knowledge, and the second really in behavioral communication or attitude and professionalism. Surgeons tend to find addressing issues with skill and fund of knowledge to be much more in their comfort zone, right? These are things that are easier to measure, both in terms of deficit but also in progress. And these are things that we do every day. We operate, we know things about patients that have surgery or need surgery. So that tends to be a more comfortable space for us. It's the other areas which I think are really the most challenging, not only because finding out the root cause can be difficult, but they're also harder to document and describe and address, and often requires leveraging resources beyond just your own program's team. We frequently reach out to GME and involve specialists to help us with issues as they come up in these different categories. The first step, obviously, is to engage, and really it's a way to start a non-judgmental conversation with curiosity. Hey, what is going on? What's happening? How can we help? It pays to do your homework or obviously ask, assessing the background or underlying issues. We frequently find health, family, or personal issues that are affecting performance and behavior at work. looking for patterns. Are these isolated things, one-off things, or is this something that's long-standing and has been observed in different contexts? Very importantly, you need to get a sense of what is the trainee's situational and self-awareness of the issue. Sometimes they honestly have no idea that there are issues, and you're telling them as an APD or a PD for the first time of a significant concern that's come up. Frequently, this is because they haven't been given timely or any feedback at all. On some occasions, you have to act urgently if there's a mental or physical health concern that sometimes needs to trump all of the other things, and that sometimes means getting GME involved or even healthcare provision as well. I'm going to take a pause and talk about feedback because this obviously, folds into this entire concept. Ideally, feedback should be timely, clear, actionable, documented, and getting followed up on. And I can confidently say that this is frequently not the case, certainly not so in the entirety of those components. And it seems to affect BIPOC and URIM trainees particularly. Our GME office and we personally have also seen some patterns where we find that faculty are at times less comfortable about giving immediate feedback to these trainees, which tends to lead to performance issues for them surfacing at a more advanced stage. It highlights that effort needs to be made not in just recruiting, but also in supporting them during training. And this is something to pay attention to. Obviously, the plan is the most important thing. And in our institution and with the way that we handle these things, either an APD or a PD or both in conjunction will typically get started off on a plan with a trainee. And there's some obvious but key components. You need to clearly identify and document the problem or deficiency. This often involves sharing feedback with the trainee. One of the areas that we've actually found to be very effective in this realm is sharing peer feedback. It's remarkable what a trainee might recognize when they're hearing how their senior resident or their peers are commenting or how they feel about their performance and how it affects them versus just hearing from faculty that may have worked with months ago about what they think and how they're doing. It's important to clearly set and document the expectations of what behavior you need to see or not see any longer, or tasks that need to be accomplished. And the final part is really giving them a framework for success. This is how we expect you to get there, and this is the definition of success. Obviously, set a schedule for check-ins. This can be very time and administratively laborious, so we work with our team to make sure that appropriate follow-up and documentation of those meetings gets done. And we also take time to inform the trainee's primary assigned mentor, upcoming rotation leads, and senior residents if appropriate. This puts more eyes on the situation and it gives us more data points and areas of input about whether or not someone is addressing the problem and improving. Once the plan is enacted, the final part of that really you need to make sure that you've defined what success is and what time frame that needs to be achieved in. This protects both the trainee and the program. We'll often take some additional steps and assign additional faculty mentors or even senior residents to offer mentorship if that seems more appropriate to the situation. And really what this ultimately results in is the first step in a plan, which is a focus of concern. And this is usually, or it is a non-reportable event and is often a 2 to 3 month timeline for improvement. And it's often the first step in helping someone address and improve an area in which they need to work on. Monitoring progress is obviously critical, and the things you're looking for are sustained progress and engagement. A frequent pattern that we see is someone addresses something right after you've discussed it with them, and then that improvement tends to wane with time. So you're really looking for sustained progress and a good faith effort to make permanent change. We as a CCC discuss trainees that have issues or ongoing plans and their progress at our monthly APD-PD meetings or sooner as needed, and we discuss all residents at our semi-annual CCC meeting. Although what you're seeing here is a path of escalation, which can happen if things are not going well, that green arrow is critical. The whole point of this process is to help people improve, and when they've achieved what is the definition of success in handling or dealing with that situation, that is the off-ramp that both the program and the trainee should want to get them back on track to routine status within the program. There are challenges that come up, however, that we don't have expertise within our own department for. There are learning and cognitive issues for which we might get learning specialists involved, executive function issues for which we can get coaching resources through the GME or the university. Much more frequently, we see mental health or coping issues, and we engage wellness counselors, even help people with medication management or guide them to that, and help them establish care with a PCP or a mental health specialist. And I'll acknowledge these resources are not available everywhere. We're fortunate to be at a large university with many training programs, so that infrastructure has been built up, but we clearly recognize that's not the case at every place. Kind of capping this off, looking at the overall framework for how to deal with someone who is struggling, we take the approach that this is a non-punitive thing. We're trying to help people get better and ultimately become successful physicians. We take a group approach to investigate and develop the right processes to help someone improve with the right support. And again, that's the engagement and an action part of this plan. And again, we set clear expectations and timelines. We have to define success, and we do this as we monitor people as they progress. You want to leverage university and program resources along the way. Pay attention to policies, paperwork, and due process. As we always say, document, document, document. And frequently, we will phone a friend in GME. We can't tell you how many times we've been given good advice or avoided errors in various events by making sure that we were doing the best thing or taking the best practice that was known through the institution. And in our experience with a systematic, thoughtful approach, we find that about 90% of problems can be solved, even if they're multifactorial. And if they can't be, you've got to be ready to take that next step, which sometimes for people is probation or even dismissal, and that's a tough road to go down. But it's something that you need to keep track of so that you are keeping progress moving, whether it's in a good direction or not. So that's kind of how we deal with the difficult trainee at the UW. It's a version of things. Every institution does this slightly differently, but we found good success with this, and we find that the vast majority of people, we're going to be able to get them through the things that are challenging for them as they train in a tough surgical training program. Thank you.